pleasure to introduce Albert O., who's director of the Fellowship for Plastic Surgery Children's, and he's one of our main referrals for cleft lip and palate. He'll come and speak with the families prenatally, and today he'll talk a little bit about how he talks to the families and educates us on the differences between the various forms and what the outcomes can look like.
Thank you very much. And again, I'd like to thank everyone for inviting me to this. It's a great place to be. Warm welcome to everyone out in the community who might be joining us here for this presentation. So getting to the goals and objectives of today's presentation are, one, I'm going to discuss some of the benefits and limitations of the prenatal diagnostic imaging modalities for cleft lip and palate. Two, we'll discuss how pre-diagnosis helps in surgical preparation for cleft lip and palate care. And then we'll discuss at the very end some of the benefits and risks of prenatal diagnostic imaging for parents of fetuses with cleft lip and palate, as this has become a area of research in the last several years. As everyone knows, cleft lip and palate will affect anyone between 1 to 500, 2,000 live births. A lot of it depends upon ethnicities and other factors. And what many people, and particularly insurance companies, like to argue, cleft lip and palate is not just an aesthetic issue. It can lead to all sorts of problems, including issues with breathing, eating and drinking, hearing, speech, and so forth. Children's, we have one of the largest cleft and craniofacial centers in the country, and we see approximately 1,000 new patients with cleft lip and other craniofacial anomalies, and we're made up of various subspecialties that meet once a week on Tuesday afternoons. In fact, I have my clinic this afternoon, where we'll see people from just all over that come in with some of these multidisciplinary issues. The primary palate, which consists of the nose, the upper lip, and the most portion of the palate, develops around 4 to 6 weeks of gestational age. So as you can see, this is very early on in the process, and many times some of these parents are not even aware that they are carrying a fetus. Secondary palate, which is the part of the palate that is behind or posterior to the incisive foramen, develops slightly later, around 8 to 12 weeks of age. And this involves the majority of the palate, particularly the soft palate, where the mechanisms for speech and swallowing are more important. Babies that are born with unilateral complete cleft lip on your left and bilateral cleft lip and palate on the right.
There's no cleft palate.
Complete cleft lip and palate.
On the left.
On the left, yes. Both of these are complete cleft lip and palate. Representative diagnostic images by ultrasound of what a unilateral cleft lip and what a bilateral cleft lip and palate can look like from the frontal view. The detection rate varies by studies, but in general, most people will agree that a complete cleft lip and palate can sometimes be diagnosed as early as 16 weeks in the gestational age. Incomplete cleft lip and palate is often later because the deformity is less severe and is often not picked up. But as I was saying, this can vary tremendously, and reports have demonstrated that some of these particularly more subtle cleft lip and palate deformities will be picked up in less than 25% of screening facilities, but this rate can be increased to 80% or higher in specialized centers. Of course, one study from Switzerland where they looked at 3D ultrasonography using standardized protocol, these researchers demonstrated that there was a very steep but relatively learning curve, and they demonstrated that after about 5 or 6 cases, there was really no significant difference in the pickup between so-called inexperienced residents and then a fetal medicine specialist. So I'm not exactly sure what that means, but I guess it means that they're it means that they're just really good teachers. From a surgeon's point of view, what we as pediatric plastic surgeons need to tell images and hear from the radiologist is what the diagnosis of a cleft is made. We want to know, is it unilateral or bilateral? In other words, is it one-sided or is it both-sided? And then we want to know on the unilateral side, does it seem to be complete or incomplete? Clues of this include the width of the cleft lip, the presence of the tongue into the nasal cavity, a gap in the alveolus. All of these pertain to complete cleft lip and palate on the unilateral aspect. The incomplete ones can often be much more subtle and more difficult to pick up. Bilateral is usually more severe, and it tends to be symmetric. I'll go into that a little bit later. But again, what we want to know is it symmetric or is it asymmetric, and is it complete or incomplete? Because this helps us to guide the families in terms of where to proceed after the baby is born. In general, the cleft lip with or without cleft palate from palate alone, because these are two very different entities. When a baby has a cleft lip with or without cleft palate, almost always it's unilateral. 90% are felt to be unilateral, with the left side being affected more than the right. Approximately 10% are bilateral, and in general, when you look at these different types of cleft lips, the unilaterals are often incomplete. About 70% are felt to be incomplete, whereas the bilateral cleft lips are almost always complete, 90% or greater being bilateral complete cleft lip and palate. And just as importantly, or more so, when a baby is born with a cleft lip, with a cleft palate, in most cases, this is considered to be isolated and non-syndromic. Finding out more and more, as many of the people in this room know, that a lot of these so-called isolated cleft lip and cleft palate babies actually do have some genetic changes with more mutations such as IRF6 and the 22q deletion syndrome, which can sometimes be seen with cleft lip, but is usually not. But we feel that babies who are born with a cleft lip are considered to be fairly isolated and have a good prognosis. On the other hand, when a baby is born with a cleft palate alone, the severity can vary. There is often some type of genetic association and syndromic diagnosis, which can then change the prognosis and outcomes. These examples from a paper we published looking at microform or what we call minor form cleft lip. And the prenatal diagnosis of this is quite rare because, as you can see in the top photographs, the deformity is really quite minor, and in a moving baby by ultrasound or MRI, you're not going to be able to really pick that up. And fortunately, this really does tend to be more of an aesthetic issue. You don't have the multi-system problems that the babies with cleft palate have, and we can often do a single operation if the family so desires, with excellent long-term outcomes. Here's a baby that is born with a unilateral incomplete cleft lip. Ultrasound images on the right-hand side, and you can see the deformity is a little bit more severe. The lip is more effective. The right nose is widened, and if we took a picture of this from below, you would see that it's also relatively flat. And often a single operation will be sufficient. The last 50, 60 years, we've kind of developed surgical flaps and techniques to repair so that all of the surgical scars are well hidden along the natural lines of the face.
And that is the alveolar ridge affected?
Can or cannot be, but in a lot of cases it isn't. But sometimes we actually cannot tell. Oftentimes these babies will be born with a slight notch or a little ridging on the alveolus on the affected cleft lip side, and it's only when in mixed dentation that we can get X-rays that will show us if and to what extent there is a bone alveolar cleft, which would then need to be dealt with at a later time.
Okay, so you won't do anything right away.
So your definition of what complete is versus incomplete?
Cleft lip and palate, I'm sorry, I could have clarified on that earlier. A complete cleft lip and palate is one that involves the entire nasal sill of the affected side, whether it's unilateral or bilateral. The lip is completely wide open, and the alveolus as well as the anagram close to your palate are completely split apart, with the uvula being involved as well. Incomplete, anything less than that. And some would be as minor as what we call a so-called Simon-Arts band, which is essentially a complete cleft lip and palate, but they have this little band of scar tissue or soft tissue at the bottom of the nasal sill, and just that little tiny piece will make a huge difference in the deformity of the presentation.
So it could potentially still have some tongue.
Absolutely. Yeah, those are less common, but certainly even we've seen here many instances where the lip will be complete, the alveolus will be intact, and then you'll have a complete cleft of the second palate behind incisive foramen. ultrasonographic images of a unilateral complete cleft lip and palate. You can see in these images, obviously we picked the ones that are the easiest to see, but you can see the nasal deformity, cleft lip on the patient's left side, the nose being widened, and the large gap in between the upper lip. Here at birth, showing what the deformity looks like in vivo. The cleft, the flattened nose, and you can imagine that this is a very, very difficult deformity to try to fix. And as I was saying earlier, as surgeons, what's important to us is that if we know that this is complete versus incomplete, it helps us to guide the family in some of the newer techniques that we use, primarily in regards to what we call pre-surgical orthodontia. And pre-surgical orthodontia is not a new concept in any way, but what it is an idea that prior to doing the soft tissue reconstruction, we can manipulate the hard tissue, that is the bone and the atlas, to bring the cleft together and potentially make future operations much easier. There is some controversy on this topic, particularly in terms of facial growth, but most of that data isn't in, and the vast majority of centers around the United States now are starting to use some form of pre-surgical orthodontia. So on your left is a mold that we've taken of a baby who has a lateral complete cleft lip and palate, and the custom retainer that is made to fit into this. And what we do is, at a small surgical procedure, within the first couple of months of life, we will stick the retainer and apply it to the upper part of the palate. And for the next several weeks, we can then manipulate the device so that it moves the cleft considerably, both at the soft tissue and at the bony gum level. As you can see here on the picture on the right-hand side, the cleft is significantly narrowed. So to do a single-stage soft tissue operation where we reconstruct the skin, the muscle, the mucosa, also address the nose at the same time. And in general, we can get a fairly good result, which looks very symmetric. The nose is often the most difficult aspect to fix with just one operation. And as you can see, this little boy, his lip looks almost completely normal. But when you look at his nose, the nose is still slightly flat on that side. We did do a good correction of his alar base width, that is the width of the nostril on the left side. But you can appreciate that that rim is just a little bit flattened. But his lip scar has really healed up nicely, and most people would look at his lip and not know that he had any type of major deformity. And really, when you compare the birth picture to his picture at a couple years of age, you can see how this type of stage procedure can get a very good result for both the patient and their family.
So when was the surgery actually done?
Typically, we do the cleft lip operation after the retainer has been put in. A retainer, again, usually being put in at around 6 to 8 weeks of age, and the second procedure at around 4 or 5 months of age, depending upon how quickly the segments move. We will then remove the device and then do the lip repair. The patients are saved until later, when they're around 1 year age, and this is primarily due to studies that have shown that the longer you wait, the fewer operative complications you will have, and the better potential for facial growth the baby will have. But if you wait too long, speech results go downhill. And so we published a large prospective study. My mentor and one of the fellows at Boston after me published a study looking at about 500 cleft palate procedures, and doing some fancy statistical analysis demonstrated that, at least in terms of the cleft palate, around 11 to 12 months of age seems to be the ideal point to maximize all those different goals. And here are images of a baby that has bilateral complete cleft lip and palate. I looked and I couldn't find a good image, at least I have one by MRI later, that shows the profile images. And the profile for bilateral complete cleft lip and palate is often the telling image from a prenatal imaging standpoint. And the reason why is because if you look at this baby after birth, you can see that the premaxilla, that is the central portion of the gland as well as the central portion of the lip, is really jutting out from the patient's face. And that there is supposed to be inside the mouth, and you can see the gum line is completely outside of even the plane of the lips. And this is an extremely difficult operation to do in a single stage. In the past, people would they try to manually force that central segment inside the lip. They also do operations where they would do wide first and then the other side. And the results of this were really quite dismal. And it's really John Mulliken at Children's Hospital in Boston who, where his long-term anthropometric studies demonstrated that some form of pre-surgical orthodontia allows you to get the best possible results.
I'm sorry to give you an image of that or two, but that's such a critical sample view to, if you're worried about bilateral clefts. If you have premaxillary protrusion, it's probably, you think it's unilateral, but it's there, it's probably bilateral, so very, very...
Right. It probably is buried somewhere in my email. But again, similar to what I was showing earlier with the unilateral cleft lips, we make a custom mold with our dentists, retainers and fashioned. And again, just like before, this is really something that allows us over the next several weeks to fit the puzzle pieces together. And this does, as you can see in this in this baby here, the premolar segment is now more centralized, and the gum line is now at least inside the plane of the lips, making the operation more possible to do. And over the years, we've kind of developed different ways of understanding how the face grows after the operation, and we compensatory changes at the time of the operation, including making a very, very thin central lip and making a very upturned nose, kind of what I describe to families, to expect a pig nose after the operation, because we really push it up as high as we possibly can, because as I was saying earlier, John Mulliken demonstrated that in the long-term results, if you don't make these compensatory maneuvers at the initial operation, the lip will be too wide later on in life, and the nose will be very, very flat. I think some people have seen this photograph before, but this is that same baby going to kindergarten. If you look carefully, you will see the scars on her face. You'll see some scars on her nose, but overall, I mean, she's just a beautiful little girl. Will be able to fit into society.
What do you do with the premaxillary? Do you get that, or do you use it?
So, well, in terms of the premaxilla, what we do is we save and work with the skin and soft tissue portion, except for what we call the vermilion. The vermilion is the lipstick line. And in the past, people used to save that lipstick line and tried to use it from the premaxilla in the repair. But what we showed was that if you, and I'm not certain if this will go in the photograph, but is your pointer? Here. Oh, here we go. This is the width of what we call the vermilion in the lipstick line, from this line to this line. So you can see it's very nice and thick, which is what most people want to have, right? So you have thick, full lips. Look at this segment; it is extremely thin. This is the vermilion here, and so you have about 1 millimeter of depth here, and usually have about 6 to 7 millimeters of depth here. And so when you, in the old technique, connected this to the vermilion on the sides to the vermilion in the central portion, the kids were often left with a very thin appearing lip in the central lip, chapped, and it was very, very deformed and did not look correct. And so Mulliken demonstrated that by removing that vermilion, that is this lipstick line in the central portion of the lip here, and using the vermilion from the lateral segments, you give them a nice full kissing lip appearance, which is what everyone wants. Again, here's a birth picture, and there's the little girl at 5 to 6 years of age. Moving on to MRI, as everyone knows, MRI is becoming increasingly used in the prenatal setting. When it comes to cleft lip and palate, there is some very good data to suggest that it is very useful. When you compare ultrasound versus MRI, ultrasound obviously advantages include that it's fast and portable and inexpensive, but the disadvantages are that there is some degree of age limit. You really can't look and reliably image the fetus until they're at least several months of age, gestational age. And there is various sensitivity and specificity regarding different centers and different experiences from the ultrasonographers and radiologists. The on the other hand, is very accurate. It's oftentimes much easier to read. And probably most importantly, it has the ability to show the possibility of associated anomalies. There's obviously include that the cost of the MRI and just the logistics of getting it scheduled, getting the family to come in, and under these a little bit more stress-invoking procedures. This is an ultrasonographic image on your left-hand side showing a unilateral cleft lip. And in this image, it's a little bit more difficult to pick up, but on the right, you can see, I mean, pretty much anyone could look at that and say, hey, there's something wrong. There's a gap the lip and the gum line. And I think this is one of the advantages where if you are able to get an MRI, the diagnosis can be much more easily made, even in just regards to the cleft lip and palate. Images of a bilateral complete cleft lip and palate, and this is the image that I was talking about before, where you can see that premaxilla really jutting out from the face and standing out where it shouldn't be. Incidentally, on your right-hand side, the one that's kind of pointing to the nape of the neck is just showing some nuchal thickening, which again leads to the concept of being able to pick up associated anomalies, because it is these associated anomalies that will often make the big difference in terms of prognosis and outcomes for these patients. When it comes to MRI, these can be picked up in a much more efficient and all-inclusive manner. One study demonstrated that up to 1/3 of fetuses with cleft lip and palate will have some form of associated anomaly. And although their study didn't go into real depth about how they defined normal outcomes, they did show some differences. And what they kind of define minor anomalies into like single umbilical artery, hand and foot anomalies, and other minor stuff like that. And then major anomalies in terms of cardiac, cerebral, or severe prognathia and others. And cerebral anomalies are often seen in up to 6.3% of fetuses that are born with cleft lip and palate. And so that slide where I was saying that in general we tell families that if your baby has a cleft lip, almost always they're going to be normal otherwise. It seems to still hold true, but 5% is still not inconsequential. And I remember probably just a couple of months ago we did see a baby in the center that had, well, we met a family, a mother and her husband who had a fetus having cleft lip and palate, and we initially thought that everything was going to be normal and everything was going to be fine, and then upon imaging we did find other associated anomalies. And these things can cause more severe consequences, such as corpus callosal issues, encephalocele, and other anomalies.
Midline defects?
No, these are the off midline ones. These the mill, regular cleft lip and palate.
Yeah, this paper, the numbers are a little bit higher than
In midline.
just for lateral. We thought it was less than 1%, so the 6%.
Yeah, and it's interesting because and it varies according to what they do. Again, this was the right midline. Midline is a completely different there's a completely.
But this is a little bit high. I mean, from
when I first read this paper, I was like, wow, 6% is really high because we usually quote a much lower number. But at least in this one side, and again, this is a European study. Looking at this, they found that up to 6% had some. Now they were counting some anomalies that were minor, like single umbilical. I don't think most people would look at that. If you saw it on an MRI of a baby with cleft lip and palate, necessarily say. Right. But actually, if these have cerebral anomalies or other major anomalies, they can determine the overall prognosis for this patient. And again, as I was saying earlier, they didn't really define what they call normal. They looked at these kids when they were in grade school, but they determined that about 50% of or more of these babies had a normal, quote-unquote, outcome if they had a single minor anomaly, but less than 5% in their series had a, quote-unquote, normal outcome if the babies had been born with one major anomaly or more than two minor anomalies. So this is kind of a sobering And it's something that, particularly after I saw that one patient with this here a few months ago, where I really felt that the baby looked completely normal. Initial ultrasound felt that the baby was normal, and then we went on to get an MRI and showed that that was not the case. It kind of fits in with an N of 1 into this type of a picture. Some more images of some of the associated anomalies. Here is a baby who's born with micrognathia and a cleft of the soft palate. You can see here a baby's upside down with the head in the intrusion, but it's a little bit difficult to see, but you can see the chin here is true and hypoplastic, and the bottom row is showing to where the tongue is above the defect, soft palate, and protruding into the nasal cavity. And here's a little bit more easier example to see of this: an ultrasound on the left-hand side and MRI on the right, where you can see that tongue, that's the T on the right-hand side, protruding above the plane of the palate and going into the nasal cavity. And this is an important issue because of the what's called P-Roban sequence, or Roban sequence, this triad of findings in babies who are born with very small jaws or micrognathia, in which they have respiratory distress, they'll have glossoptosis, and these often need to be addressed very early on so that these babies can breathe and survive. Yet another MRI image of a baby with cleft lip and palate showing holoprosencephaly and bilateral pleural effusions. Again, these are picked up on an MRI, which may be picked up on ultrasound as well too. In fact, a lot of times they can be, but the MRI is a much clearer picture. And here is another image here with baby having blind ventriculomegaly and interventricular cardiac defect on the bottom picture below. Sorry. So, is it worthwhile? It all depends. If you look at the benefits of prenatal diagnosis and the MRI to help show some of these things a little bit as an ultrasound, I think one could argue that it is. Some of these benefits include ability to really plan for our pre-surgical orthodontia. It also helps in the detection of associated anomalies. Process of termination can also be at least given to them, something based on the MRI, and the information and the preparation that we can give to families is often very helpful and has been shown in multiple studies. Overall, most mothers prefer having a pre-diagnosis. At least to one study, it was interesting. This study felt that the mothers responded saying that they preferred to know about the diagnosis of cleft lip and palate fairly late in the pregnancy, as this kind of took away their, of they should choose to have an abortion. But yet it was enough time for them to get over the initial shock, and short enough time that they didn't have months and months of waiting and stressing before the baby was born. When you look at termination rates in pregnancy, it varies tremendously. 10 to 90% is what's quoted. And interestingly, there's a spectrum here, and the research showed that, at least in looking at various studies around people, and Jewish people tended to be the ones that terminated the most, whereas in Western countries, the termination rate was much lower.
And this is even with just a unilateral.
Yeah, and a Korean person that in Korea, the ejection rate for unilateral cleft lip is quite high. It's staggeringly high, and it has to do, I think, just like all over the world, but people wanting to have babies in general, wanting to save all the resources for that one or two babies that they choose to have, and not wanting to start off with advantage. And this was from out of China. They looked at the stress of foreknowledge, and these mothers stated that they felt 5 major components, and it included loss of self-value as a mother. They felt that they were somehow responsible. Their stress of potentially having an abortion, the anxiety of really not being able to understand the diagnosis. And I always tell families when we come to the fetal center that there's no test or quiz at the end of my presentation that I give to them. And I when they walk here, you guys will, I tell them you probably will remember only 5 to 10% of what I'm telling you today. And I always stress them, the main thing that I want you to go home with today is to just understand that you're in hands. We're going to be able to take care of this. And this is something that we do day in, day out, all the time. Looking at some of the stresses for the family, including potential disadvantages to the baby and to the mother. Study, all the mothers told the researchers that the ones that decided to keep the babies to term, they did not regret the decision. In conclusion, hopefully, we've shown that there are these various prenatal diagnostic images that really can provide valuable information for both the families as well as their healthcare providers. Primarily, knowing the diagnosis ahead of time helps us in pre-surgical planning, particularly in the very complete cleft lip and palates. In regards to the risks associated with the family, research shown that most mothers really feel a lot of stress associated with this, but if they decide to keep their babies, they do not regret the decision to carry the baby to full term. Thank you very much, and I think I've left enough time for questions.
What do you need from us as imagers in our report?
I'm going to go back here to this slide here because that's the question. Thank you. Where did it go? Rhythm for what it is that we would like to know. Okay. When a fetus is diagnosed with a cleft lip, we want to know, is it one-sided or is unilateral, or is it two-sided or bilateral? And beyond of that, if you can give us a hint as to whether or not you think it's complete, that is involving the entire palate, or whether it's incomplete, that's also helpful. Look at in terms of the bilateral cleft lip, if you can tell us if it's asymmetric or symmetric, which can be difficult to do because, as I showed photographs, a lot of these babies with bilateral complete cleft lip and palate, that premaxillary segment is actually not in the midline, and it often looks like it's unilateral because one side is pushed over and you can't see the defect. But to it is, just as Dr. Vilas was pointing out there, is that sagittal view. If you see that premaxilla jutting out from the face, that's a bilateral complete cleft lip and palate.
Bilateral incomplete can still be cleft lip and a great deal of the palate.
Yes.
So I think I'm going to struggle to know for sure the difference between a unilateral that includes a bit of palate and a unilateral complete. I
think that's the challenge that all the centers have around the country, is that it's hard to make that diagnosis. And what I tell families is, I tell them, if you're going to go to Atlantic City and you're bet on whether or not your baby has a unilateral complete or incomplete, and you're going to bet that it's going to be incomplete based upon the epidemiology. And I tell them that as a way of reassurance, because if it's incomplete and the involved or whatever, prognosis is in terms of their speech outcomes, in terms of their eating, drinking outcomes. But I still tell them, if they are part of that 20 to 30% that will have a complete unilateral cleft lip and palate, the pre-surgical orthodontia, we have the surgical flaps and techniques to be able to deal with that.
Now, then, improved procedures, like with ear infections.
Ear infections is that's another area of controversy. There are definitely some centers, NYU in particular, that have shown, at least in retrospective series, that doing a cleft palate repair helps with the incidence of ear infections and hearing loss later in life, but most centers have not shown that.
Any reasons to deliver in certain areas? They could deliver in their community hospitals. Do some hospitals are showing the families how to see the baby? Like, any kind of reason?
Yeah, that's a great question. In general, this area, most of the larger hospitals have some experience with babies being born with cleft lip and palate. Some of the communities probably do not, and we've certainly had babies come to our clinic and, the families tell us, wow, we were in, I don't want to mention any places, but we were at such and such a place and they really had no idea what to do. For the ones we're fortunate enough to see as prenatally, at this center or just up in the plastic surgery clinic, we stress to them, give them time to meet with our nurse coordinator, who is a national expert in feeding babies with cleft lip and palate. She will sit down and spend 30, 45 minutes with them, showing them bottles, different feeding techniques, so that if the baby is being born at a place where they're really not that familiar, the family feels like they kind of got it. But I think some regions, obviously of the country and of this area where they just don't have the volume and the experience to really deal with that. And so that's a real stress for families as they're preparing for the birth.
Is that part of counseling? Do they, if you need delivery, they get taught dues or just calling?
I know that in terms of, again, another great question, in terms of the ones that I see and my partners see with you here at the Fetal Center, all of them are given the opportunity to meet and speak with our nurse coordinator. And most of the time they do take that opportunity and do very good about sitting down with them, whether by phone or in person, to talk with them about feeding strategies. And
when do you ask to see them? Like at an age, at a month of age?
Usually I ask for them, not to see me as soon as the baby is popped out. I say, you've got enough things going on in your life. Once you're settled in your home and everything seems to be okay, come in and see me sometime in the next couple of weeks after the baby is born.
So there's nothing they need to be on prophylactic antibiotics, or
that's correct.
No special type of feeding.
Well, the feeding does require some specialized feeding, but
so
again,
they can't really breastfeed, but they'll use the bottle.
Right. So breastfeeding is, there are women who are able to successfully breastfeed their babies who are born with a cleft lip and palate. In general, the more severe the deformity, the more difficult it is for breastfeeding to be done. I use the analogy of trying to drink through a straw that has a slit in the middle of it. And when you're sucking on it, you're getting just as much or more air than you are of the liquid that you're trying to get in. And so a lot of times with breastfeeding, these babies, as they're trying to feed, they're sucking in so much air into their stomach, it takes forever to feed, they get colicky, they fall asleep, they don't get enough calories in, and so they poop out to have failure to thrive. And so what I tell families in that situation, particularly because breastfeeding is obviously so important, is pump in general. Go ahead and pump your milk, use the bottles that we do, and then towards the end of the feeding, go ahead and suckle with your baby to get that bonding interaction.
Well, thanks for the presentation and amazing results. So we're very lucky to have you. Anyone else have questions from the community that's listening?
All right. Thank you very much. Thank you.
Thanks a lot. That was great. We've never really formed
I know we've met kind of in hospital functions, so it's nice to see you.
Yeah, thank you. That was